Hello friends, today we'll be talking about acute bradycardia. Okay, what is acute bradycardia and what to do during bradycardia? And first thing first, what's the definition of acute bradycardia? According to American Heart Association, we define bradycardia as a heart rate of less than 50 beats per minute, or if there is pause of more than 3 seconds, okay, more than 3 seconds, that results in symptom or hemodynamic compromise. While ESC, European Society of Cardiology, in 2021 it defined bradycardia as a sinus rate of less than 50 beats per minute or pause of more than 3 seconds, okay, during wakefulness, okay, wakefulness with symptom or risks of asystole. So, in both of these cases, they have not only given the number, are also concerned with the symptom. Okay, they are both concerned with the symptoms. So, acute bradycardia is not merely the presence of low heart rate; it also should have the symptom. Okay, after that, what does book says? Harrison or Davidson book. These books, both of the book says bradycardia to be the sinus rate of less than 60 beats per minute. But Davidson also emphasize, okay, it also emphasize the rate down to after determining the stability, then only we go further. Okay, if there is unstable bradycardia, then that means there is problem in perfusion. Okay, problem in perfusion, and there will be signs of instability. Okay, then what are the signs of instability? If there is hypotension, systolic blood pressure of less than 90 mmHg, if there is altered mental status, okay, altered mental status, if there is chest pain, if there is dyspnea, sign of pulmonary edema is there, or if there is syncope or pre-syncope. If any of these are present, then that means the patient is unstable, okay, not stable, and we have to go further to treat this patient. Okay, after determining the stability, we should also know if whether the patient is symptomatic or not. Okay, symptomatic bradycardia means the heart rate is slow, along with that there is symptom present. Okay, and this symptom should be due to slow heart rate, not any other thing. Okay, and if these are if there is symptoms of due to slow heart rate, then we have to manage as per ACLS protocol. Okay, ACLS protocol of bradycardia, I will be talking about that later on in this video. If the patient is asymptomatic, okay, if the patient is asymptomatic, which means there is no symptom pertinent to slow heart rate, okay, then we'll observe the patient, we'll evaluate for any reversible causes. For this patient, there is no need of immediate treatment. Okay, no need of immediate intervention. What about vestibular bradycardia? This is a term where symptoms cause bradycardia. Okay, the symptoms cause bradycardia. What are the symptoms that can trigger bradycardia? Okay, the symptoms that can trigger bradycardia can be pain, vomiting. Okay, if we do carotid massage, okay, this can cause bradycardia. In this case, we have to treat this primary condition. Okay, why this symptom came in the patient. Okay, after that, if the patient is symptomatic or asymptomatic or vasovagal bradycardia, okay, after that we'll localize the block. Where is the defect in this patient? We'll look for the ECG to find which type of bradycardia is this. Okay, if there is, what do you mean by sinus bradycardia, what do you mean by junctional bradycardia, first type block, Mobius type 1, type 2, complete heart block. Okay, sinus bradycardia means there is a normal P, normal P, there can be prolonged RR. Okay, normal P, QRST, if there is normal, then that can, if there is normal P, presence of P, QRS and T wave, then that is called, okay, sinus bradycardia. If there is no P wave, okay, or if there is retrograde P wave, if there is narrow QRS, okay, then we call this junctional rhythm. For first degree AV block, the PR, duration of PR should be more than 200 millisecond or more than 5 small box. Mobius type 1, there will be progressive PR prolongation, progressive PR prolongation, and there will be dropped QRS after certain time. In Mobius type 2, the PR will be fixed, but after certain time there will be dropped QRS. Okay, in every heart, in complete heart block, okay, there will be AB dissociation. P wave, it will have its own rhythm, QRS will have its own rhythm. They do not synchronize. Then that is called complete heart block. We should categorize the bradycardia according to this. Okay, after we have ECG. Then comes what are the reversible causes and what are the things we have to search. Okay, this can be remembered with a mnemonic BRAS, Brady, BRADI, Brady. In Brady, first comes BRAS syndrome. Okay, BRAS syndrome. BRAS syndrome means there will be bradycardia, the patient will have renal failure, the patient is under AV block, the patient might be having shock and hyperkalemia. We have to immediately treat this patient with to manage mostly hyperkalemia, giving insulin, dextrose, calcium gluconate, and albuterol, salbutamol nebulization will treat this patient. After that, R for reduced vital sign. Okay, reduced vital sign. What can be the vital signs which cause bradycardia? Like hypoxia, decreased oxygen can cause bradycardia. Decreased glucose, okay. Hypoglycemia can cause bradycardia. Hypothermia can cause bradycardia. Hypothyroid can cause bradycardia. We have to find this also, okay. After that, A for acute coronary syndrome, okay, acute coronary occlusion or acute coronary syndrome. ACS can cause. If there is inferior MI, okay, inferior MI, then that can cause bradycardia. Drugs like beta blocker, CCB, digoxin can cause bradycardia. I for increased ICP, intracranial pressure, any infections like of Lyme disease, endocarditis can cause bradycardia. These are the reversible causes which can cause bradycardia. We have to find this to treat the patient of bradycardia. After this, we will be talking about the ACLS 2024 management criteria, how to manage a patient with bradycardia according to ACLS. This is followed for symptomatic bradycardia patient. Okay, immediate action. First of all, what to do immediately? Immediately, we have to give oxygen if saturation is less than 93%. Okay. After that, we put the patient in cardiac monitor. We put this patient in cardiac monitor. We'll open IV line and we'll do ECG. Okay, and we treat reversible cause. We find and try to find and treat reversible causes if possible. Okay, this that can be remembered with mnemonics of Brady. Okay, Brass syndrome, any reduced vital sign, A for ACS, D for drop, and I for increased ICP or infection. Okay, then comes drug immediately because the causes, sometimes the causes are hard to find immediately. At that time, we give atropine. 1 mg of atropine is given. Remember, it's 1 mg. Okay, of atropine IV bolus. This is according to AHA guideline 2020. Okay, they told 1 mg atropine should be given, not 0.5 mg. Okay,